see events like this here in different cities around the country and soon other countries. We had planned on doing it this last year, going to Barcelona, Berlin, etc. Last time we were in Chicago was actually 2016. We did it at Matter. Matter wasn't open yet, so thankfully DePaul came forward, thanks to Paulo Machado and Barbara Rapchek, two of our great partners and sponsors that work with us all over the place. So the whole idea of this event is to find really great startups and to engage and to have great discussions on topics that are relevant to us, people who are interested in healthcare. And who are us? They're patient activists. Anybody here a patient in the room? People who are patient activists are people like me who get upset and excited and engaged in trying to change healthcare from outside healthcare, essentially, from within the system as a patient, but not really within the system. Care providers are also very important. So if you look at the MedStarter logo, it's actually four stakeholders holding hands: patients, providers, institutions, and partners. You'll see that our panel today, as well as a lot of the startups and a lot of people in the room, represent all of those things. I was a healthcare CIO when I was a kid. I also started a bunch of companies, some of which affected your lives in some ways or another. So that's pretty exciting. But now what I get to do is I get to find startups that are doing really great things and helping them along. So we have an amazing portfolio of companies. We started a venture fund in 2017 and an accelerator as well. So we accelerate a lot of companies. So today you've got but I'm not the arbiter of what is cool in this place. It's actually you guys. Okay, so you notice in front of you are forms. I think that when we're all engaged in new ideas in healthcare, it's going to do a bunch of things. One, it's going to help the startups get forward faster because people are going to say, hey, I like that idea. I got some suggestions for you. Maybe you can come to my hospital and we can do a pilot or what have you. Or maybe I want to invest, right? So those kinds of interactions happen at these events all the time. Very first event I went to back in April Fool's Day 2009, that probably tells you something. But I saw two people meet. One had a pill bottle with a scale in it. The other was a marketer. They made a company, and that company did really well. We also saw ZocDoc form, Able2 form, Medable, Misfit Wearables. These are all companies that pitched on our stages when they're not companies or had just gotten started. So you've got some amazing panelists tonight. They are mostly here, but also, and they'll introduce themselves in a bit. I just want to take you through some of the basics. MedStarter, the MedStarter Momentum World Tour, we talked about that a little bit. So after this, we're going back to New York. We already did an event in New York. We did one in Orlando and Philadelphia. And those are small and they're getting bigger. So it was 3, then 6, and last Monday we had 12. And so today we have about 40 people registered, which, look, I understand that reopening the world is not that easy, but we're just the kind of people to do it. Because when we usually do these events, we get 100 to 2,000 people at big conferences and things like that. But we're really excited because you have some amazing startups. You've got amazing, brave panelists who came here tonight, and all of you. So we're getting back to being open. Everybody vaccinated? Let me just check that. Vaccinated. Anybody not vaccinated? Somebody raise your hand if you're not vaccinated. We're all just like, riddle you, why aren't you being vaccinated? I did it to somebody this morning. I do it every day to somebody. Anyway, so we love having these events. Why? Because we love helping startups get going faster. And we know that folks like you in the room, especially the panelists, are the kinds of people that can help startups. And then when they say they're excited about an idea, we get excited about it, and we put them into the due diligence process, and then we invest in and accelerate the best companies. So this is the schedule for tonight. This is me blathering on for a little bit. Usually we have alcoholic beverages. I'm sorry Paul will not let us have them. We are going to go out afterwards, so if anybody wants to go drinking with us, we'd like that. Not to drink with necessarily, more the social interaction. Then we're going to hear from Rachel and Pat. They're going to talk about trends in healthcare innovation, which is exciting because they're both associates in venture firms. Usually you hear some old man like me talking about it. I didn't want to hear myself talk. I actually would much rather hear them talk. And then you see what they have to say on the topic. Because I think they have really unique perspectives. I mean, Patrick has seen so much stuff. I'm sure Rachel has too. So I asked them to get together and do that. It's actually mostly Rachel's talk, but Patrick's added too. And then we've got 7 amazing startups, some of which we met on Clubhouse, some of which we met before. And that's been a really great experience, Clubhouse. If you guys don't know what Clubhouse is, you can ask me or Sandra or Pat, who spent a lot of time there, and we do things. And then we're going to have a little networking break, and then you're going to get to hear from the panelists. Now I'm going to sit up here, and we're going to have a discussion on what the future of healthcare innovation is like in COVID. And this can also be a general discussion of people who pipe in with questions or comments or whatever. I'm going to do some light moderation there, but I mostly let them talk amongst themselves. And I send them a bunch of questions to think about, but I'm sure they all have interesting thoughts on the topic. So that's pretty much everything else. We run a venture fund. We already talked about that a little bit. Judging. Okay, so there's two ways to judge, and you guys are all judges as far as I'm concerned. Here's what I want you to do. Either use the paper, and if you need a pen, there's some pens floating around. You can do that, and this actually has two sides. So the first side is the actual judging information, but the second side is also very interesting too, because this is if you really want to get involved in any of these companies, mark it down. We'll make sure that they find out, right? So we'll collect all these at the end, but also you can scan this barcode, and it takes you to bit.ly/mmjudge, MedMo judge, and that is an online version, and it's going to make Tony's job a lot easier because he's doing the data entry. And if you're wondering why a contestant is doing the data entry, he actually already won a contest. He's already been through due diligence, but I want to hear an update from him. I want to see how he does, and I want to help go forward even faster. The rubric is pretty straightforward. It's written on the bottom here. Basically, would you give them your money? How clinically relevant is it? And all the other things that are written there. You can do that on your own time. So we started out as a meetup group where we had events like this. So this is kind of like our DNA, things like this. And then we started MedStarter, which MedStarter.com was the first healthcare crowdfunding site. It still exists, and you still use it for contests. And more about MedStarter. We got a lot of stuff about MedStarter. So the mentor network is very important. People ask me, well, how do we help these startups so much? Well, it's because if I call Con and I say, Con, there's this MRI innovation, I'd like to have you have a look at it or talk to them or whatever, they'll actually talk to them, right? Because Con's first spoke at one of my events in 2016, we have him on Clubhouse sometimes, and I consider him a good mentor that I can point people to and say, I know this guy, one of the smartest guys in healthcare, he knows this space really well, and if Con likes it, then I'm going to like it, right? So that's kind of how it works. And it's a huge network. There's over 1,000 mentors in it. People who started Change Healthcare, people who started Health 2.0, and just really amazing people. Special thanks to especially Pat Hurd up there in the audience. You're going to see from him later, he works for me. But also Jessica Purser helped set things up, and Deanna Pindar, who's like that. And all sorts of other folks, and people from Matter, and Paula Machado particularly, and of course each others. So we have other sponsors and things like that, and especially in this case with DePaul University. So that's pretty much all I have to say at this particular point in time. Patrick and you guys want to come up and do your trends in healthcare? While Pat is setting that up, I'm going to ask the judges and panelists who aren't going to be active in this particular point to introduce themselves a little bit, just 30 seconds each while these guys are setting up their thing. So you want to start out, Brad?
Sure. Good evening, everyone. I'm Brad Flugel. I spent most of my career either consulting to or working in health plans, including three of the biggest ones. And then my last corporate gig was at Walgreens, where I was the Chief Strategy Officer and Chief Commercial Officer. And then I semi-retired about 3 years ago, and now on a handful of boards, and then advised and invested about a dozen early-stage healthcare companies.
Very cool.
Rohini. I'm a biomedical engineer, and for the past 20 years I've developed software solutions and driven digital transformation initiatives at global organizations. The past 12 years I've really focused on healthcare IT, and most recently at a health system where I helped develop a electronic health record from up. And now I'm working on my startup. It's a digital health startup focused on consumer behavior change. And really excited to be here, and good luck to all the founders presenting today.
Awesome.
I'm Hans Dieke. I'm the Chief Medical Officer and Chief Strategy Officer currently at Hyperfine. Prior to that, I was founder of Piggy, based out here in Chicago. Before that, spent time with Microsoft running engineering teams in the health group and Xbox and a few other places. I'm a diagnostic radiologist, practiced for 10 years, faculty at Maryland Hopkins before I was doing that's my background.
Everybody got it? There you go.
Hi everyone, my name is Sandra Washington. I am a patient, and I'm a patient advocate more importantly. My goal is to teach patients not only how to speak
So Mamta Swaroop is the only one not here yet. She went to the wrong building. So she's our physician representative. Are there any other doctors in the house? Anyone? Yes. Oh yes, of course, Karen. So feel free to fill in for Mamta. So there's a doctor in the house. I dropped out. So
right? Is there a doctor on the flight?
Well, Dr. Khan is in the position as well. Anyway, yeah, so now I'm going to leave it to the youngins. And sorry, as the 50-year-old plus, you know,
I'll take it. I'll take it.
So, do we know how to turn the lights off over here? Just because you guys are.
Is that hard to see?
Oh no, this is fine, but you guys look very dark. Okay, so let me turn this to you guys. And of course, take it away.
Okay, thanks so much, everyone. We will keep this brief. Today, we're going to talk very high level about where we see the future of digital health going in what we're calling a peri-pandemic world. I'm Rachel Stillman. As he had mentioned, I'm a senior associate at Seven Wire Ventures. We're an early stage digital health focused venture capital fund investing acutely in this thesis that we call the informed connected healthcare consumer, which I'll touch on momentarily. And so really going to be looking at the future of health today through the lens of what this means for the consumer. Patrick.
Hey everyone, I'm Patrick Hurd. I work with Alex at MedStoyer. I'm an associate there. I'll be helping Rachel give her speech, and towards the end I'll be saying some trends that I've noticed through healthcare innovation. I'm happy to present with her.
Great, thanks Patrick. So don't need to tell this audience, right, that today's healthcare system is broken, but certainly just want to level set on what are some of the challenges that are underpinning the system that really are shaping where digital health is going today. Obviously, rising costs is something that no one in this audience is not aware of. Today, we have over $10,000 spent per capita across individuals in the U.S. healthcare system. Access barriers, gaps in insurance coverage and declining outcomes continue to plague our system, and so really setting a nice opportunity, if you will, to drive change in digital health. And so these systemic challenges are really fueling this concept, which we at Seven Wire call the consumer hassle map. So thinking about the 5 core tenets that are really driving challenges for the healthcare consumer, and where there are opportunities for digital health organizations to really drive change across transparency, quality, cost, access, and coordination. Of course, everyone knows, right, that COVID has further intensified many of these challenges and creating new needs for the healthcare consumer, which Patrick will talk about later on in our presentation. Most notably, I would say, some of the two primary trends and needs coming out of the pandemic, of course, is the second pandemic, right, of mental health challenges. Today, nearly half of individuals in the U.S. have anxiety and depression, which is just, again, a rate like we've never seen before. And we now have a surmounting level of deferred healthcare needs that have taken place throughout the pandemic, and a new type of consumer that's really open and looking for opportunities to receive their care remotely. And so because of this, the new healthcare consumer is very eager and excited to try digital and telemedicine solutions. Particularly, I'll flag that over 2/3 of individuals are now receiving their mental health services virtually, which is just, again, a rate that we haven't seen before. And so again, I'll flag these trends as Patrick talks about what we intend to see in the future of digital health. But mental health is certainly one of the core challenges where we see quite a bit of opportunity to drive change. And what's most exciting is as we think about some of the willingness across consumers to try digital health solutions, we are even more excited about the fact that many of them are loving the experience that they have when engaging either with a telehealth service or with a mobile platform. And so we see this as really an accelerant for some of the areas of adoption and acceleration, for the broader industry going forward. At Seven Wire Ventures and how we see the future of digital health, we really look at the industry through this lens that we call the informed connected healthcare consumer. And so thinking about how do you leverage digital health solutions to transform patients into what we call informed connected health consumers. So purposefully thinking about how can digital health really provide individuals with technology, data, information to ultimately become stewards of their own healthcare journey and transforming them from this concept of a patient that receives reactive care into a consumer that has a greater interest in and decision-making role in their healthcare experience. And so as we look forward, many of the solutions that we get very excited about are ones that are amplifying this idea of an informed connected healthcare consumer. I'll also flag some trends that are underway, and I'd be remiss not to talk about some of the regulatory policies that have either been approved or are in discussion about the permanency of some of the virtual care platforms that have occurred during COVID. Most notably, the telehealth or the Telemental Healthcare Access Act of 2021 is currently in discussion, which if passed would open up a whole new door of opportunities for Medicare patients to receive mental health care virtually. And then on the Medicaid side, we've seen a ton of activity at the state level that is really helping eliminate access barriers, expand coverage, and hopefully provide some level of reimbursement parity for Medicaid patients who are receiving their care virtually, and really helping to address some of these access and barrier and geographic barriers. So because of all of this activity that I just described, we have now seen an unprecedented amount of digital health funding. When I was putting this data together, I had to double check the numbers because it's quite frankly astounding. COVID, of course, has amplified, I think, what already was an accelerant and a trend that was happening in the industry, which was the shift from digital health, which 10 years ago was kind of this new sector of technology, to one that has really gained widespread adoption and has started to mature. And so because of that, we've started to see new deals come through that are later stage, larger sized rounds, and much more mature. And so we think those mature companies will really fuel a lot of the market activity going forward as we move outside of the pandemic into this new normal. And with this unprecedented rates of funding, we've also seen quite a bit of activity in the form of mergers and acquisitions and exit opportunities. While some of the M&A activity has slowed and transitioned from private market consolidation to public market exits, I will note that we have seen a different type of acquirer enter the industry. So 5 to 7 years ago, it was primarily exits from private equity organizations, providers, or health plans, and now we're seeing quite a bit of lateral mergers and acquisitions within digital health. I'll flag one of our portfolio companies just because I can't help myself, Livongo and Teladoc, which I think was kind of the starting race of some additional lateral expansion that we plan to see in the industry as some of the larger, broader players acquire some of the smaller point solutions. And so another kind of big event of this year, right, has been much of the public market exit activity we've seen, not just through IPOs, but of course through SPACs, as again, I'm sure many of you are aware. Oscar, I think, is probably the headliner in 2021 as it relates to traditional IPOs, but we've seen a ton of healthcare SPACs enter the industry, most notably Clover Health, Hims and Hers. And so as we look forward, we are really excited about the market's interest in acquiring digital health solutions. And also that now analysts understand how to evaluate digital health companies, whereas 2 to 5 years ago we were having discussions about how do you even think about valuing and understanding the business model of digital health. So it's really just been a pretty transformative conversation in the past 2 years, and think that this is going to kind of fuel additional investor interest into the market. And so now as we look forward, I'll transition it to Patrick, who we'll talk about some trends that we are thinking about as we look ahead.
Thank you. Thanks, Rachel. As you said, these are some of the major trends we see in healthcare. The first one I want to talk about is that with the adoption of telehealth and home care, patients are now able to receive care at a cheaper and more comfortable environment. Like you said, 2/3 of patients are now receiving mental health, and I believe 60% of patients are having telehealth appointments with their doctors beforehand. But also, I think a major trend that we see in the United States is elder population, and as the elder population increases, we see that home care startups and major companies have been growing rapidly at about 20 to 30% year over year. And I believe as the population keeps aging, we're going to keep seeing that increase. Mental health services has exploded in the last few years. No longer is it a taboo subject to talk about any issues you're going through mental-wise. It used to be an issue. And we see companies from meditation companies like Headspace, who now, I believe last year raised $96 million funding-wise, to companies, I'll bring up one of our portfolio companies. Sorry, I just got nervous.
Sorry, you're doing great, man.
Valera, yeah. Thank you, Alex. A company we invested in, Valera, which brings telepsychiatry to the patients. And these telepsychiatry companies are great because they're bringing care to people who usually won't be able to receive these mental health services, whether it be underrepresented communities or people in rural communities who there may be one or two psychiatrists in the county, let alone the town. And thanks to these new services, we see they're finally getting the care they need. And one of the biggest things I believe we're going to see is consumers are more connected to their data now. They're able to use RPMs, remote patient monitoring. They're able to see what they're doing, how they have to change. And a big thing that goes into effect in about 5 hours is the CMS Data Interoperability Act, which will require Medicare and Medicaid patients to have direct control over their data. So now they're able to actually bring their data and require insurances and providers to share data to apps or to future providers and new providers are going to. And this is going to explode the opportunity for patients to actually receive new care and be connected to the care that they need. And another major step we see is health equity. For a long time, as I'm sure everybody knows, like underrepresented communities such as Black, Latino, Asian communities receive worse care in the United States than their Caucasian counterparts. But over the last year, especially, we've seen that people are addressing this issue from the fact that they're making companies directly for these communities, or the fact that clinical trials or pilots and stuff like that make sure that these communities are represented fairly, such as like the LGBTQ. Now there's a requirement that these people have to be in these trials for it to become validated. And some special companies I've seen, like they focus in, such as like the Indian population, and they just focus on training AIs for that one specific group, which is a big step up from last year. I believe that most of the AI startup companies, they mostly just use Caucasian populations, which have different determinants of health. So basically all of this coming together is that these patients now are able to receive care that they need. Whether it be from a wearable, from talking to doctors through telehealth, through Zoom, through whatever they can, it's able to really connect these different parts of the community together and the stakeholders together. Thank you.
All right. Not bad. So that concludes the warm-up portion of our show. And now we're going to have judges. Actually, we're still missing a judge. So Mom's not here yet. So Patrick, you got to get back there. So now we're going to have our first startup. Come on up, right? That's where we're supposed to be in the schedule. Is that right?
Yep.
Okay, so Grapevine, led by, you can put the name here. Hey, you go.
Box, Phil.
Oh, yeah. Your application. So, the amplifying us here. So here's how this works. Patrick's your timer. Right, Patrick does everything.
Let me get my phone.
So you have 4 minutes to talk. Okay, that's it. They're going to get 4 minutes to ask you the hardest questions they can think of. Okay, and you got to cover what you know what you're doing. Patrick will basically signal you time, and I don't know if you know, my last name is Fair. Like contests, I try to make them fair. Right, so you only get 4 minutes.
All right.
If you do go over, they're probably going to ask you the questions you forgot to cover, like your ask or what have you. And everybody out there in the audience, I do want you to either use the online form or the paper form because I need your input to figure out if I'm going to invest in Bob, okay? Because my investors want only the best. So, and since I'm one of my investors, I also want to invest. Anyway, okay. So, timer, are you ready?
Yeah.
Okay. You get your clicker. This is definitely really it's your Look at it, you've got the right colors.
Trying to smooth you a little bit here, so.
Don't say everything else. Anyway, so okay, so this actually is the live stream for. Hey guys, sorry I wasn't in front of the microphone. For the live stream.
No, that's for Clubhouse.
This is for Clubhouse, right? And this is recording audio, and that's recording video. So whatever you say, we'll be looking at.
All right, here.
Okay, so I will get out of the way and shut up. Judges, please make sure you ask hard questions.
All right, hi, I'm Bob Thoman. I'm president of Brightbot. I've been around for a year now. I'm here tonight. I'm looking for some investment. I'm looking for some partnership in marketing, manufacturing, and the clinical areas. So I want to bring the Brightbot UVC protocol to more than the 56,000 hospitals, ambulatory clinics, and nursing homes throughout the U.S. and then throughout the world. That's what I'm trying to do. So I'm a physician assistant in the ER. I'm also an electrical engineer. When COVID hit, last year we weren't prepared. We didn't have enough PPE, so I started making UVC lights to help sanitize rooms after the COVID patients. From that I noticed that, hey, these rooms, well, I've known it for a long time, the rooms aren't that sanitized. So, we use our normal cleaning protocol, or I follow the normal protocol. So I wear gloves, I gown up, I put masks on, I go see the patient, I touch the patient, then I grab an otoscope, and I touch equipment, and I touch the curtains. Like, how often do they clean curtains? Like, never. So I thought, I could do something to make this better, so that's how Brightbot came around. So, I love the name of the event, MedMo Reopen the World, which is great after COVID, but I don't want to go back to where we were before COVID. A world where, hospital and healthcare environments are never satisfactorily cleaned. It's unacceptable. So that's what I'm doing here. So what's at stake? Hospital-acquired infections. So the cost of this, 2 million patients are affected by this. There's 90,000 deaths a year, and 25 billion to 45 billion dollars a year are spent on infections that we don't have to have. How do we normally do it? Normally, housekeeping goes in after a patient's in a room. They wipe it down, they mop, they change the linens. If they want to clean it better, sometimes they use UV lights. And the stuff out on the market now, $25,000 to $125,000 for a light. They're complex. They have software. They have digital interfaces. That's all fine, but it's inefficient. You can't use that across the hospital. It's too expensive. It's not easy to use. If you put them at the end of the protocol, it adds time to your cleaning process, which then slows down patient flow. It just doesn't work well. So that's why I came up with Brightbot. My most expensive unit is $8,900. You can put it in a room. It's simple enough to use that nurses or techs can put it in a room after the patient leaves. Leave it in for 5 or 10 minutes. During the time it takes the cleaning staff to get there, so you're not adding time onto the cleaning process, not stopping patient flow. It's cheap. You can buy 10 to 15 of them for the price of the stuff that's out there right now. So I want to do it on every infectious room, or in every patient that has an infectious process. Clean the rooms, clean the walls, the pathogens that are building up patient after patient after patient. So that's what I'm trying to do here. So costs per year, there's no software, no licensing fees. It's about $500 a year for replacement bulbs. That's it. This is a kind of a picture of one of the units. Anybody can use it. A tech, a nurse. You can put it in a room. You plug it in. You shut the door. Remote controller. You turn it on. Leave it on for a specified period of time. Take it out, and you're done. So anyway, let's see where we're at here. Change. So what are the benefits? You keep the rooms cleaner. You protect staff and patients. You don't add time to your cleaning protocol. And staff satisfaction, you keep people around. Hospitals can use it for promotion to the public. Hey,
Sorry, time.
we're done. All right.
Okay, so we've got 4 minutes for the judges, and I'd like to, don't start their time yet. Mamta Swaroop, friend and physician, has arrived. So Mamta, please introduce yourself. She's sitting right here.
Right here. Hi, my name is Mamta Swaroop. I'm a trauma critical care surgeon for the last 11 years. I also run a not-for-profit organization called the Satana Foundation, and currently we have a campaign going on called Unite for India, which is what we are working on, and we are providing aid to India for the COVID crisis as well as for the aftermath.
Yes, and I actually got to know her through the United for India project, which we work on together. And we've raised, what, $250,000? Hundreds of concentrates, all sorts of other stuff. So really exciting project. Anyway, so would you like to ask the first question?
So as opposed to other cleansing lights, UV lights, why yours versus any other light?
Our price point, we're a lot cheaper. Like I said, it's simpler to use, so anybody can use it. It's not a complicated thing. Our hospital was going to buy one 3 years ago, and it was $100,000, and they couldn't get it. It was 3 FTEs to use it. So just the price is prohibitive.
But looking at that unit, it doesn't cost anywhere near $8,000 to build it, does it? I mean,
no.
Why is it so expensive? Is the
What I
market?
found out was, people look at other units that are $100,000, and they look at mine if I charge $4,000, and they're like, why is yours so cheap? What's wrong with it? So that's why.
It's fluorescent bulbs on a stick.
Well,
It's,
so why does it cost $125,000 for the other one?
because it's healthcare.
Okay. All right.
So what is the,
But is there something that's preventing someone else to say, why 8,200? I'll give you one for like $500 or something.
Oh, okay.
I mean, what I'm asking is there any technology there or any patentable piece to how you changed the product?
Does mine have anything super exciting compared to anybody
that
else?
someone else can't replicate
No.
Do you have
for
IP?
cheaper. Yes.
No, but I'm doing it cheaper than all the other people, so.
but why couldn't they just
No.
decide at some point to match that? I mean, if there's not an innovation that's creating your ability to get that, other than, is it lower supply chain costs, or is it just that you're not?
You're going to have to ask them, because I don't know why they charge so much. My goal was to get something out there to keep us safe and do it as quick as possible. And part of this is the protocol too. So it being so cheap, you can put it at the beginning of the protocol, which nobody does. Infection control always wants to put it at the end. And being cheap enough, you can do it in a lot of rooms. Like we did this in my ER. So for last year, all the COVID patient rooms, we sanitized them. The techs put it in there, cleaned it for 5 to 10 minutes, and the cleaning staff came in. It was a seamless process. Everybody felt a lot safer. Patients liked it, staff liked it. I'm like, why don't we just do this everywhere?
So it's deployed now?
Yes. So I have 11 of them at my hospital. We've been using them for the last year. It's allowed me to kind of tweak things over the last year and get it to where it needs to be. So.
I do have a question.
Yeah.
Is that just for hospitals, or is that also for like skilled nursing facilities where we
Yes.
have an overabundance of people that have
Yeah, absolutely.
infections?
So I think anytime can't have it in the room with the person, you know, it has a remote control, but, you know, for example, I'm donating a couple of them to a pediatric oncology camp, summer camp next month, so they can use it to clean the dining rooms and, you know, different rooms in the camp for the kids and stuff. So you can use it, dentist offices use it there, nursing homes would be great, healthcare facilities anywhere. So.
How do you think about scaling your commercialization in the box? How do you scale your commercial?
You know, obviously I need to partner up with somebody. I'm doing it myself, so right now that's, I'm learning that, you know, this is my first time doing this, that's not going to work for a large scale. So I need to, you know, hook up with a manufacturer and somebody can market this. You know, they're relatively easy to make. I can make one, in, you know, after I have fabric, you know, all the metal fabricated, I can put it together in about, you know, 1 to 2 hours, you know, per piece. So, you know, I've started advertising on, you know, medical device sites and things like that. I'm talking to some of the bigger, like Sodexo and these sort of people that do environmental services, you know, that have hospitals across the country, things like that. So.
Great.
That's not informative unless.
No, informative is good. We've got some companies to get to. Okay, so if you guys haven't done this, yes, round of applause for that. Anything you're doing is very important. And while we get the next speaker up, I will explain to everybody what we're supposed to be doing now. So, I'm rather proud of the scannable part that Patrick put in. Interesting trivia, I actually wrote the first software that connected bar phones and cell phones like in 1999, and we're got 9 patents for it, so I'm also proud of that. Anyway, but so what you can do is you can use the paper version, and I want you to think about whether this has clinical benefit potential, whether it's feasible, that it'll work, whether it's innovative, whether if it was your money, you would give it to them. In fundability, you think you get an investment back, whether you think it's scalable. Now granted, you know, he's at a very early stage, and he doesn't know all the right answers, but those things you can be taught. Anyway, so presentation quality and how he did this presentation. So, so tell us what you really think. And you can offer to share some or all of it with the startups. I think of it as it's important to tell people what they're doing wrong early on. So I think, you know, be cruel to be kind is actually not a bad thing. So please don't pull any punches. People need to hear what they're doing wrong. Yeah. So anyway, so I just did my first one on my phone. It's very easy. Thank you, Patrick, for creating that. Oh, Brooks is here. Sorry.
No problem.
Okay. Patrick, you ready? Yep. Is everybody done with the first judging? Everybody? One more time? Try to do it good. Did yours at the first day. Sorry. Anyway, okay, so Brooks won one of our pitch contests on Clubhouse. We're good on time. So, take it away.
Well, thank you, Alex. Thank you all. I'm here to talk to you guys today about fall prevention as a service. And that's health.ai with 2 P's like patient privacy. This year, next month, marks 21 years in healthcare for me, specifically around patient experience and patient safety. I'm under 40, and I'm really motivated and excited to move on to my second startup. I currently have a first startup. It's forward thinking. That's forward thinking, and what we did was, I had a close friend that died of a hospital-acquired infection in Denver, and I decided to found forward thinking, and what I went after was, I went after Purell as an investor as well as a partner. So that startup currently OEMs to Purell and another Chicago-based company called Rollin that does call light systems in hospitals. I built a really good, strong team around myself, and then again, OEMing this platform really allowed me to move on to some other things. I build strong teams. That's what I do, and that allowed me to again move on to this next thing. $34 billion a year is spent every year in patient falls related to patient falls in hospitals. Our solution is an AI-compliant nursing assistant. I have a quick demo here to show you. I don't dare do it live, but let me play that.
I can vouch for it. It is pretty
There was a video here. Oh.
Basically makes you into a stick figure and it tracks all the places.
Well, I'll just talk through this. So, what this is a demo for when you would put a patient in a chair in a particular patient room. Generally, if they're a high risk to fall patient, you don't want them to get up on their own, so you stick them in the chair, you give them their call light button, and you let them know to call the nurse when they need to get out of bed, or in this chair. In this case, out of a chair. What this demo is showing here is I can sit on my couch in my office, and it will know whether or not I'm sitting or standing. I can show this video later if you guys have some more questions. But what this would be is a camera that sits into a patient room. This is an embedded camera. It can also sit on an iPad. Anecdotally, we found that there's about 40% of all patient beds currently, because of COVID, now have an iPad at bedside, and we'd like to leverage that as a potential vector to get this pushed through. What happens is this camera will sit in the room, or an iPad, will watch the patient. If they're in a bed, it creates an alarm. If they try to get out of bed, it triggers a bed exit alarm. Because this can predict that, we can predict up to a minute of early warning before the patient actually falls. Most of our current competitors generally is a bed exit alarm in the bed, and if they try to get out of bed, oh sorry, I keep forgetting. If they try to get out of bed, an alarm will go off. However, generally the problem with these is the patient's generally on the floor by the time the alarm goes off. So the injury has occurred, there's not a way to prevent that from happening. These are the injuries from falls in a hospital. This was 2016 numbers. So 245,000 to 350,000 patients fell while in the hospital and potentially could have been injured. Generally what happens is 6 additional days will be added to their stay, creating a 26.9% readmission rate. Once they're injured and leave the hospital, generally 26% of them will come back. That's all on the hospital's dime too. The moment that fall occurs, those 6 additional days, that can add up between 8 to 16,000 up to 30,000 per incident. Generally, if somebody falls, they'll probably fall again, and that would extend that day from 6 days to 14 days. Long-term care also is where another place this can fit in. 29 million falls happen, 3 million ED visits, and then out of those, 800,000 hospitalizations, and then 28,000 deaths. It's almost as much as car accidents per year.
Brooks, I'm sorry, time.
Just finish up and.
Okay, I'll be quick. I'll be really quick. So market size, 13 million beds worldwide, just under 1 million beds in the U.S. We have access to a network of highly trained distributors across the world that I've worked with in my previous startup. Our analytics, we can get good analytics that can come out of this. Our model is $780 per bed per year as a service, so that's a SaaS model. So we're not providing this from a capital purchase. We're bypassing all of that, and we're going straight to OpEx budgets to try to move this forward faster. Here's some of our competitors. Most of them are multi-focused or really expensive. There's another competitor over here that's pretty expensive, but they're focused, but they're not using technology, they're using people. So here's our team.
Let's move on to Q&A.
Sure, no problem.
Because this cuts into your Q&A time.
No
So you're
problem.
only at 4 minutes total, so let's leave some time for questions.
Has it been validated? What evidence have you pulled together that is actually working?
So anecdotally, we pulled together evidence. We're getting ready to start some clinical trials with the NIH. Clinical trials, we're not FDA. We're not necessarily going after your FDA just yet, but more of initial clinical trials to validate our product. We put a hospital room into a video game engine, and that's how we trained our AI. And then we've been anecdotally training that with our hospital partners. We're starting our initial trials with the NIH as well as some other hospitals in Texas this month, or actually in July.
Do you have an IP around this stuff, and how are you preventing others from what's the IP moat around this?
Sure. So our IP moat is going to be through a technology transfer from the NIH as well as from NASA. We're really far stages along with them, along with the product, and both of those organizations very much like to transfer technologies to things that make sense outside of their current fields.
So you have exclusive rights? You have exclusive rights on it?
We haven't gotten quite that far yet, but there are a couple of the patents. There's about 8 patents that we're working through from the NASA portfolio that will give us access to those things Some will be exclusive, some will be not. It really just depends on the original inventor and kind of what their process is. So each one will be just a little bit different, although we will have access to that IP to really protect
But
it.
altogether, it will make one patentable
It will make-
system.
yes.
Are you going to patent that?
Yes. And we do have some patent pending things written around that as well.
Operationally, what happens after the alert is sent out, typically?
The goal would be, it would go to some level of a rapid response team, like a code team in a hospital. Some group of nurses in that unit, they would need to know if the patient's about to fall. Because we can get up to a minute of early detection, that minute's really critical to get out to a team to help prevent that patient from falling.
Right, which is, I think, what needs to be validated, because the reason I asked the question is, would there be alert fatigue, eventually? And
Sure.
Has that been something that you...
My previous life, we spent a lot of time around alarm fatigue, and the idea here this would be even less alarm fatigue. It would be more prescriptive and precise on exactly what's happening and what's occurring in the patient room. Things like, is the patient awake? Additional use cases, extubation, pulling your ventilator out on your own, seizures you can detect from rapid eye blinks. Those are all things that we're going to be getting downstream from the NIH technology transfer, but stuff that we've built into the product already.
Okay, one more question?
Do you want to take a question from Clubhouse, Alex?
What's that?
Do you want to take a question from Clubhouse?
Do they have one?
They're asking me, yeah.
Sure. You can turn the volume up on that and ask them. Just to ask, do you have a question? Say, Clubhouse, do you have a question for me?
Clubhouse, do you have a question for me? It's going to be a little feedback.
Okay, any other questions? So much for the wonders of modern technology and virtual events. Well, more questions? Oh, one more question? So you didn't really talk about your 3-camera setup or anything like that. I mean, can you show us what it looks like?
Absolutely.
Show us the device.
Let's see,
It sits in the corner of a hospital. I can't believe you don't have, you should have brought the device.
I have one in the back.
Okay, so that's the best.
So this has several sensors in the device that allows us to get a variety of different things. There's a 4K wide-angle camera, there's a see-in-the-dark camera, and there's a LiDAR sensor. That allows us to see in this room under any lighting circumstance.
Okay, so I think you're out of time. Thank you. Big round of applause for Bruce. Okay, so a couple teachable moment things I think you have here, right? One, if you have a device, like he has a device, bring it. Always bring it, right? 2, practice your timing, right? Because you want to get through everything, right? You don't want to not be able to. 3, if you have a Clubhouse event and you ask them for questions, you guys should ask for questions. They can't see mine. So, Tony Stearns, Dr. Tone is up. He also plays music too. But he actually won our last live event. See, Princess Pride. He won our last live event. So he is actually here to give us an update. So he's really not in the contest per se, but we like what he's doing and we like to be able to help him. And shout out. And he's going to the Walgreens bed first. Perfect. Okay, so do you have your decks ready?
It looks ready to me. Yeah.
Okay. So Patrick, I got your timer here. Yep. Okay. Let's start.
Hi, I'm Anthony Stearns. I'm the founder and CEO of IRX Reminder. We're moving mental health patients from crisis to control. Patients are disengaging at about a 25% rate from mental health agencies today. It's not a small number. It's 4.8 million individuals. And this frustrates staff, and their turnover rate at mental health agencies is around 40% annually. And that leaves about $24 billion in lost revenue on the table. And on top of the crisis of getting less and less reimbursement for every activity they do almost every year. And we think that the core problem here is that there's no remote monitoring. We only know what happened to the patient when they're in front of us. So this is my grandparents, and they lost their independence because they weren't able to manage their medications into their late 80s. And so I've seen the need for this technology personally. What IRX Reminder has developed is a simple, powerful solution built around an app and an Internet of Things pill dispenser that then plugs directly into an electronic health record at the agency, which can then trigger activities by the care team and increases reimbursement. So we get this triple win of helping the patient, pointing the staff where they're needed, and helping the agency's bottom line. The core of our technology is this pod, but really the innovation is introducing a dosing window. And when you enter the dosing window, you can take the pod, you grab it on top, place it in your hand, tilt it, and the pill comes out. Sorry, when they put me on an IBM, I always get a bad video. Can't be helped. When you take it on your own, you get no alert. It just shuts down and it's ready at the next dosing window. But when you're forgetting, that's when you get an alert, the second half of the dosing window. And you're reminded, and it's only when you're completely forgetting that you trigger an intervention from the care team. So you get that remote monitoring that's missing. The agency itself fills the pod, so they have an additional economic incentive to adopt. The method's far safer for patients because the medication's always contained. And the situational smart alerting has been proven in many studies in 22 of our research customers to move adherence from 48% to well over 80% with even with cognitively impaired patients. So our business model is you have a 4,000 person agency, they're going to earn about $21 million a year, but because of disengagement and staff turnover, they're losing about a third of that. But with our technology, they can do additional monthly med reviews. People show up for their therapy. They're now monitoring reimbursements and then additional interventions as they intervene. And so you make about $10 million extra from about 20% of the agency using our technology. So that's $10 more million to help more people, a 40% net increase. What makes us different is being plugged directly into the electronic health record, in addition to our patented device and methodology. And I can talk about the comparisons, I'm sure I'll get asked. So it's an $8.6 billion market at a bottom-up estimate. And if we take the 20% of agencies we can plug into today, it's a $350 million market today. What we're working, we started with NIH I-Core in 2018 with mental health. We used our SBR money to complete that. We actually got issued the patent 3 days after we won the American Medical Informatics Association Award that MedStarter ran in Washington, D.C. Then we ran into COVID. But since that time, we've been able to do 4 cloud-only demos, and we're now signed up with an agency to begin a full beta, including the pharmacy integration, while we also need to complete our FDA Class 2 clearance, and we'll be ready for commercial launch. What those betas will prove is pharmacy integration, staff response times, and prove our reimbursement metrics. But we have high confidence all that's going to happen. Yeah, that's fine. This is my team. We're looking to build, carry out those demos and build our inventory. And I hope you'll join me in moving patients from crisis to control to achieve and maintain independence.
Okay,
Thank you for your time.
Slightly less than 4 minutes for Q&A. Questions? Brett?
I do have a question. As a patient advocate, where does the patient fall in the midst of using that tool for them?
At therapy, they work with their therapist to learn how to use the device relatively quickly. It just takes a few minutes. They take that home, put the charging stand in their home, and they're in total control of taking the medication. So what we find is that you get fewer, more meaningful alerts as you get better at taking your pod, taking your meds. You just get alerted very infrequently when you're forgetting. And then if you're making a decision to get off your medications, if you're a bipolar patient or something like that, then we can set that as a high priority to contact that person and have a discussion about why they want to get off their meds.
Why not? Can I ask a really dumb question?
Sure.
What's the agency in this context?
The agency is the mental health agency.
Sorry, Sam.
Have you done research on that particular form factor that you got?
Yeah, we have.
I couldn't figure it out, but that's because I don't get trained on it. But users like it, patients like it.
Yes, once they again, you need about a minute and a half of training, which I've which a little bit of practice and then everything's very, very normal. It's like, once you understand that it's like using a computer mouse, it all comes together.
How to deal with dosing differences, like if they want to titrate the dose of the patient and they have to take it back and refill? Or?
Right, so it's a smart pill bottle in effect, so it's a 30 or 90-day supply, and it's filled by the pharmacist. I call it a cognitive prosthetic, so if the light's on, basically you can take it, but this particular one's opaque, but you could see the medications and know what you're taking.
Can it hold multiple medications?
So each pod is designed for one medication, one type of medication, up to a 90-day supply, and then we hook them together next to each other, like you would the 5 pills bottles that you'd have otherwise. So now you just can't overdose on them, and we have remote monitoring. But you're making a behavioral decision to take them every day. It turns out that unlike a temple of pills or text reminding that's yelling at you every day to take your pills, this puts you in total control, and you always feel and encourage a positive behavior. So it has a totally different vibe.
I understand the use in opioid, but what about beyond opioid? What are the thoughts on?
Oh, no, it's intended for critical meds. We're using, the study we want to do next is with Latuda. Opioids is another case, so we can give them more than a 3-day supply. This version isn't locked, but we have a locked design for opioid specific.
How do you think through competition? I know you mentioned you were going to get asked, but
Yeah, so one of the things is that we're far more portable and flexible because we can use one pod or many. You can place them at different places in the home. We're tied directly into the EHR. Our whole model is selling to an agency. It's not a consumer product. So we're in a relationship to help people take critical meds over the long term.
So, another good question. I mean, so you're going through the agencies, you used to research stuff. Why aren't you going to Walgreens? You know, I mean, why isn't this just like every pill should be dispensed like this?
Because I think in the long run that is the model, but the win for an agency is really powerful, helping the patient.
Realistic revenue increase.
Yeah, we get a 5-factor return on investment for the agency that wouldn't be present for Walgreens. They just get the fill. Though Walgreens could use that big box of pharmacists they have for their specialty pharmacy to have those conversations with patients to convince them to stay on their bipolar medications, for example.
Sorry, I'm probably missed that money. How much you charge per patient?
We're at $10 a month plus the cost of pod. But they're earning activities that are equivalent to 5 to 8 times that.
That's fine. Okay. Great job. If you all take a moment, fill out your forms or your online thing, that would be great. Patrick will get the next speaker queued up. You guys having fun? This is interesting, right?
Yeah.
Some good startups. I know it's 4 and 4. There's really not that much time, but with 7 companies, it's good. If you guys want, anybody's getting tired of this, we can take a break before if you guys want. It's a pretty small group, so. Also, I wanted to thank you all for coming out. It shows bravery, because obviously not all of us are ready to go out and vote yet. Okay, so we should be at our 4th company, right? So every place labs a last-minute applicant, which I thought was very interesting, doing stuff. So thank you for coming out. And time, are you ready?
I actually tested them.
Oh, you tested them?
Yeah.
Oh, I saw that.
Thank you for inviting us.
Okay, every place labs. Take it away.
Hi everyone, my name is Claire. I'm the COO and co-founder of Every Place Labs. We're developing a self-service diagnostic kiosk that brings reliable, rapid diagnostic tests to patients in community settings. We're currently a company in residence at Fogarty Innovation, which is a medical device incubator affiliated with Stanford Biodesign. So as we heard earlier, there's been this tremendous shift away from traditional healthcare settings to telehealth over the course of the pandemic. But due to limited access to rapid testing during telehealth visits, most patients are still choosing in-person outpatient care for visits that require diagnostic testing. So our mission at Every Place is to bring rapid diagnostic tests to wherever patients are, and we're starting with the workplace. So our initial offering is focused on influenza and SARS-CoV-2 testing for the post-pandemic workplace. We are hoping to help employers reduce transmission as well as absenteeism associated with respiratory illness and help identify any unexpected cases of COVID-19. For our target market of large self-insured employers, that's a $1.2 billion serviceable addressable opportunity for us that we're really excited to get started with. So our solution is a self-service kiosk that is designed for simple patient-initiated testing. We enable high clinical reliability by automating manual steps that are performed by healthcare workers today in traditional settings. So this technology will enable on-demand diagnostics so that more patients use cost-effective virtual care for visits that require diagnostic testing. So how does this work? Meet Sue. She's an essential manufacturing plant worker who's feeling sick at work. Sue would fill out an online screening and triage tool using her phone, and based on her symptoms, an Every Place lab test would be ordered. At that point, Sue would be directed to an Every Place equipped office or wellness room in the worksite, where she will check in at the kiosk. Based on the test that is ordered, the kiosk would dispense a self-testing kit. She would be instructed to collect a sample, in this case a nasal sample. She would place the sample back into the kiosk, and then at that point she can leave and expect to receive results in 15 minutes. So once the results are available, they're sent both to Sue as well as a remote provider. In this case, Sue has tested positive for the flu. So the remote provider will contact Sue proactively, in this case prescribing Tamiflu, which is an antiviral medication. She takes the antiviral, and because of the early intervention, she's able to quickly recover and get back to work one day sooner than she otherwise would have been able to. So for the employer, what we're really looking to do is reduce healthcare costs and absenteeism. So we're able to generate about $200 in healthcare cost savings by automating the diagnostic testing and also by shifting patients to lower cost virtual care settings. And we're also able to expedite recovery and reduce absenteeism by enabling that early diagnosis and treatment. We are able to turn any location into a point of care lab, so there's no capital equipment cost for the employer. We charge a 50 cents per employee per month fee, up to $3,000 a year, and a per test fee of $40 per test. And that membership covers access to the kiosk, integration with a preferred remote provider, whether that's an employer health provider or a telehealth provider, and we're able to kind of automate everything else like test replenishment and kiosk maintenance. So our platform, we're starting with these 2 respiratory tests, but ultimately we're hoping to expand to a broader range of tests, including drug testing, other routine acute clinical tests, as well as chronic disease screening and monitoring. And really this platform can be implemented in a wide range of settings beyond the workplace. This would include pharmacy settings, retail settings, convenience stores, even homeless shelters where there may be access to care today, issues today.
That's fine.
Okay.
Sorry.
That's okay.
What exact test are you doing? Is it PCR?
Yeah.
And what equipment is inside the kiosk?
Yeah, so we're running antigen tests.
So the kit that the form goes in, everything's in it or something?
Exactly. So today the point of care antigen test is essentially a test strip. So you collect your sample, you place it in a vial, you have to squeeze it and apply reagents, and then you place it onto the test strip and then you wait. So we automate essentially that entire processing step. So all the patient has to do is swab themselves and place it into the cartridge.
And you're sourcing that test from where?
Yep, so we're going to be sourcing it from existing test strip manufacturers that have already developed antigen tests. There are a number of them that have not yet received emergency use authorization in the U.S. that are looking for essentially a path to market. So we'd be working with an existing test strip manufacturer.
So you guys build all the robotics and all the stuff to do all the manual process?
Exactly, yeah. So we have completed an alpha prototype where we've demonstrated comparable accuracy to the BD Veritor antigen device. And our beta kiosk will be complete later this quarter. We'll be doing a pilot with an employer partner later this year.
I do have a question. That is going to be at an employee site where the employer, well, it's going to be at an employer site where the employee can use it. What past or what testing have you done or surveys have you done to test HIPAA? Because that is going to be information that will be at their employer. A lot of employees will actually not, there's a possibility that a lot of employees won't use the test because they're afraid that their employer may get information that they will not have. So how does HIPAA work into, how have you worked HIPAA into ensuring that the patient is, their information is not actually?
Yeah, that's a great question. Actually, employers brought that up when we spoke to them. So in order for the patient to share the information with the employer, they will have to opt in. So without opting in, the patient will have the information themselves. It will only be sent to the remote provider for treatment purposes. We do, however, aggregate data at an anonymized level so that employers will be able to see whether there's an influx of positive cases, but that will be anonymized data.
Right, but that's for the employer. When I'm talking about the employee, where they have the option to being able to use that. How is their HIPAA going to be protected?
Yeah, so the employee opts in to share the information. Otherwise, that information is not shared with the employer.
Who's cleaning the station, if you don't mind me asking?
Yeah. So there's essentially an automatic, within the device, once the waste is generated, our device actually converts any type of regulated medical waste into normal municipal waste. So any janitorial staff would be able to remove the trash can from the device and dispose of it. No extra janitorial services need to be hired for this.
What is the capacity of the system? Like, how frequently do you need to replenish?
Yeah, so it really depends on the utilization and the type of program that the employer has. If you're just using it for basically symptomatic uses as employees select to use it, then it would be automatically replenished based on the rate in which the tests are being performed. So we would actually proactively ship out test strips based on the rate of usage. If an employer has implemented a broad screening program where employees are regularly screened, then we would automatically know to replenish it more frequently.
And it's just shipped to them and they know how to replenish it?
Yeah. Yes?
I'm wondering if you have stats on the accuracy of the tests that are self-administered versus being administered by a healthcare provider. I've had a COVID test before, and I feel like it was a brain biopsy almost. They're jamming it up there, and I can't imagine doing it on my own.
Yeah, so there are actually two types of COVID swabs that you can do: a nasal pharyngeal swab, which is the kind of painful one that goes all the way up, and a nasal swab, which is, I think, the more prevalent one that is used for self-testing. So self-testing has proven to be just as accurate in terms of getting a sample that's usable for the test. We're able to reduce some of the user errors around preparing the test strip because we're automating that process. So ours are going to be a little bit more, it's going to reduce the user errors that could be associated with, for example, home testing that would be done today.
Thank you.
Great, that's fine.
Thank you.
Please go ahead.
All right. So that's very interesting. It really just shows how little time 4 minutes is. So I will encourage folks to try to get their talks done in 4 minutes. So you do have time for Q&A, and definitely audience questions are always welcome. So thank you. That was a really good question. And yes, I feel exactly the same way. And actually, the first one I did came out negative, and because they let me do it myself, and I had no idea how far he was supposed to do it. Okay, so Peter, you drove in from Pennsylvania, is that right?
Yep.
You're as bad as us. Anyway, so go back there. Pat, open the clicker. You want to? No, I don't want to do it for you. So next up is Open Solution, another last-minute entrant and a long-distance driver. Everybody ready for this? You guys weren't ready for a break? Or we got 2 more, right? After this, we got 2 more. So
Keep it rolling.
keep it rolling. Up to you guys. Okay, so it's not like we've got great tricks out there anyway. So I would also like to say special thanks to Paul University for hosting us tonight. And also, if you win tonight, you get one of these wonderful snow balloons. In addition to our attention from our due diligence team, who actually, the leader of that is out here in the audience, Sharad Mishra. And big round of applause, Sharad Mishra. Sharad Mishra. He found me, he's a total crazy person. He started a venture fund. We have no idea what we're doing, but we're doing okay. So he also works for some big company as his day job and some other venture fund. So, Sharad Mishra. Anyway, so Peter, you have 4 minutes. You know how this works. Try to get it done in 4 minutes. Try to stay behind the podium because there are people listening from here. This thing is supposed to be recording.
Yes.
Well, we're recording 6 other ways, so we're good. So, yes, take it away.
Okay, my name is Peter Gineb, and I represent the Open Solution company. We use for this particular reason. Now, I take from point Patrick's and talking about CMS and effort to centralize or to move data in hands of regular public patients. We sincerely believe for many reasons, more than one, that decentralization of the data, moving this data from places where we have right now to the hands of consumer is most expected event. It will happen. Sooner or later it will happen. And what it means that patients or regular people will use data for this particular reason. However, when CMS issued this request, question would be what kind of device, what kind of mechanism, system would be used to store this data in hands of people, in hands of public. Now, a few years back, we built a system, information system, kind of system for many reasons, for many applications, but effectively a system which allows you to build and to develop and to make your presence on internet good enough, and it will be done what we call right now no-code development. So effectively, if you have data, give us data that we just crack our engine, and you will receive complete set of elements, software elements like not physical or logical it would be, and application, specific kind of, in this particular case, application for maintaining electronic health records. Our fact is that it's not only electronic health record. It needs to be maintained in centralized or to decentralized fashion. But many others. In presentation, you will see it looks like it will take longer than 4 minutes for me to present this case. But system, how system looks like, this is result what we achieve, business use case, what you achieve with when you will move data in hands of consumer. And obviously, in this approach, everybody will be beneficial. It would be good for payers, it would be good for healthcare providers, for patients, and medical data providers. Medical data providers would probably suffer a bit because data would be in the hands of patients, in the hands of public. Now, construction technology. How the thing, because CMS issue request, but how it will be practical implementation, it's left behind, and nobody give answer. years back, as I said, we developed system of this kind. In this system, you will see stack all components, what needs to be presented, even in hands of every single member, every single patient, every single person. So, sorry about that.
Okay, so you didn't really get through a lot of your stuff.
No, I did not.
Yeah.
It's kind of big stuff. And what effectively I try to say, I'm taking the questions. I work quite a few years in healthcare. I have some knowledge, in some places fundamental knowledge. So to produce this system, to make EHR effective and useful as we hope needs to be done, many questions has to be resolved. Like for instance, clinical data exchange, part of EHR of course. How to do that? And in many places it's done in many different ways. People try to use SNOMED, CT, and other their own, but this is not regulated, it's not, and no interest to the business to do anything. The only interest is government, CMS. Without government, without CMS involvement, it would be very difficult to move this thing around. But good thinking, not necessarily good, but good thinking is like we know what needs to be done. So we identify all technologies. Sorry.
Is there a product here?
Yes, this product.
Okay. Do you have customers?
No.
Who would be your customer?
HIE, Health Information Exchanges. It would be based on ideas.
I know what HIEs were.
Yeah.
That many of them around anymore.
Yes, we have very good layout currently. We do have HIE organization. We do have insurance, Blue Cross Blue Shields, aligned with specific.
So how are your conversations with customers going?
Well, it's going on. It's no practical. Okay.
Other questions?
Yeah, so there are established standards for healthcare
Of course.
interoperability, right? Like HL7 Fire.
No, but HL7 Fire, okay.
Yeah.
First of all, yes it does. I apologize for interruption. But the point is, to move from HL7 to Fire, it's not necessarily very simple thing. And not, I don't know.
So I totally agree with that statement. But what is yours
What is
doing
different,
that's different
you know,
and better?
than someone else who's implementing these standards?
Well, because we know how to do that. This is probably the only rational answer. We know what elements needs to be in place. We know how to put this thing together. We simply need some support and coalition, organization who will do this thing, who will participate in this thing. Without this stuff, you know.
I think what I'm trying to understand is that what problem in that entire, there are multiple problems that you described, right? So what is the one that you're trying to focus on and trying to address?
All of them.
But what, can you articulate some
because
examples?
to attract and to prove the point, we have to touch all components, all structural elements of this solution. We need to think about what kind of standards, HL7, Fire, what interoperability, what clinical data exchange. All this stuff is still solved in many places in different ways. HIE failed. Let's see this in this way.
Any more questions? No? Okay. Okay. Thank you, Peter. That was interesting. Not what I thought it was. Interesting. Thanks for driving up. I'm sorry. You know, when we review I thought there's more of a part there. Sorry about that. So our next up, and please fill out the forms. And if you're using electronic form, you can't stick one. You have to fill it out. But the paper is nice and easy. So, next up is Dolitech. Great. Your flying mouse is here. Oh, you brought a product to show.
I did.
What's it called? Okay, so Clubhouse is listing here. This is your clicker here.
Got it.
And timer's over there. You try to do it within 4 minutes. There's a plug over here.
This is prototype
Prototype number 2, very cool. Okay, so this doesn't count as your 4 minutes yet. So, when he starts talking, that's when I start.
All right. Hello, everyone. I'm Isaac Chapman. I am co-founder and CEO of Dolitech. Now, I want you to imagine something real quick for me. Imagine if you could diagnose any disease, any bacterial, viral, or cancerous disease immediately. I'm going to reset myself real quick. It's okay, right?
It's good you guys.
All right. Imagine if you could immediately diagnose any disease, any cancerous, bacterial, or viral disease across geographies within 5 minutes without the need to add any new expensive hardware or require any specific training. But all you then need to do this is instead have over-the-air update to already an existing device, like this. This will change the paradigm of how diseases are currently diagnosed and how future diseases will be added to healthcare systems. This is what Dolitech will do. Dolitech has roots in Kenya, as the name is Swahili for medical technologies, and it's where my aunt died in 2013 due to a lack of access to technologies. At the time, there were only 2 MRIs present in that country, and that pissed me off because I currently live in Oak Park and I can walk 4 blocks to get an MRI if I really wanted to. This made it so that my brother and I started Dolitech so that no one else suffers due to a lack of access to technology, the same way my family did. So, the problem that we're trying to now tackle with this is the time it takes to diagnose a disease. Right now, it takes about 2 to 8 days to diagnose most diseases. And in that time frame, the physician is going to do one of 2 things. First, they'll either overprescribe some medicine, or 2, they'll do nothing. Both of which increase the treatment costs, both which increase the chance of malpractice for the physician, and result in worse health outcomes for the patient. So our solution to this is a device. That's version 1. This one is version 2, trying to make it more sleek and more wanted. Load the screen up. Our device is to have a portable point-of-care device that physicians can use to diagnose disease within 5 minutes. This does several things. First off, because you're getting diagnosed at an earlier time, this decreases the treatment costs and improves health outcomes. It decreases the chance of malpractice, and the physician actually gets to make money administering these tests versus paying an outside lab to actually run these same tests. The way this works is very simple. It's a laser paired with machine learning. The laser is able to scan a sample. So this is a little vial that has a reagent into it. You just put saliva into here. Sorry. You put saliva into here, and then the laser is able to get the chemical signature. And then our machine learning algorithm is able to diagnose diseases using that same chemical signature, and you can do different diseases all at the same time. This allows us to have a subscription-based business model where we will charge a monthly fee to get updates on current diseases and for updates on new diseases that we add to the platform over time. And the first disease we're going to deal with is COVID-19 strain differentiation, which we're going to actually do an IRB study to test for all the 4 different strains that are currently active right now. So far, we have done $37,000 in friends and family. We have completed 2 proof of concepts where we can detect
bacteria and saliva within saliva, so in saliva with 90% accuracy. And right now, we're planning to do an IRB study, and we're raising money for that so that we can show the FDA that this can be used in a clinical setting, and then help us get insurance to purchase this, which can then execute on our letter of intent that we just got from Chicago Clinic.
Isaac, you're running out of time. Make sure you tell people about how the ramen spectroscopy works, your ramen works.
Oh, I was going to say that for questions since I didn't have time for this. But simply, you use a laser, and the laser excites a molecule, which sets it to vibrate like this. Our machine detects that vibration, and then we use the machine learning algorithm to say, hey, that vibration at this frequency, that means this disease. Or if it's at another frequency, because each cell will have a different frequency based on what's outside of it, then we can pick and choose whichever frequency we want to detect, and that represents what the actual disease will be.
Great, that was highlighted. Great job.
Okay.
So, you know, one at a time. Ladies first.
Sorry. Can you talk more about the validation level of each of the tests in different diseases? Like how much data is
Okay, so right now, when we tested for, we did two tests, right? The first test was a test for lactobacillus kefir, and we put that in saliva. We did that because we don't have a lab, and I needed some way to detect for some bacteria, so we chose that, and we were able to detect that with a 95.7 specificity and 98% sensitivity.
Actually, sure, go find
Really, this last one.
This doesn't count. Oh, you're gonna dance to it? So, no, tell them about why your ramen spectroscopy detection.
Perfect timing for
Ramen
you, huh?
spectroscopy's been around forever.
We can talk over that, that's not a problem. We can still work, don't worry.
Yeah, I'm not sure.
I guess we're gonna take a networking then. Okay, Isaac, finish it up. Now let's discuss questions for Isaac. Tell us about your ramen spectroscopy.
Let me answer her question. It was about validation. So we've done two proof of concepts for testing for bacteria that have 95% accuracy of bacteria. And COVID-19 was 90% accuracy. Right now, what we're for a specific bacteria, or specifically one bacteria in saliva, and specifically COVID-19 in saliva. Right now, we want to clinically validate it, and that's what we're raising money for, $400,000. We already have a clinical partner in Florida who's a hospital that's ready to go. We have a PI who actually won one of the NIH the COVID-19 grants for running it. He had the same technology we had, but he's now switched over to outside because he believes our technology is better than what he was working on at first. So we have that, and that's why we're trying to raise money so we can validate it and then show the FDA, here's the data, make us like this.
I'll ask the same question about IP, like what is your IP, how are you different from other ramen spectroscopy?
So our IP is a process patent that we've already filed for provisional patents for in the US and internationally. What makes us different is that we're doing a generic approach of the nanoparticles versus a specific. Meaning, most people will say, I have said tumor, I'm gonna target this, I'm gonna put an antibody to target this thing specifically. The problem is you miss all the human immune responses and other possible targets you could be missing. So we just said, why don't we just have the nanoparticles bind to everything and then use the machine learning to find the differences for us and then use that approach to now diagnose multiple diseases. So that way, let's say if we're doing saliva and we want to test not just COVID-19, but we want to add flu or we want to add like oral cancer, we don't have to change anything, just the machine learning algorithm to just detect something different. That's what makes us different from every other person that's using this.
Have you looked at your optical way of doing it versus the MR way of doing it? I mean, there are other superceramic iron oxide nanoparticle based methods that use more of the RF way to do it, or you're using optical lasers, right, to do this?
Yes. We picked this, well, one, this is what I studied, and I did a lot of experiments creating protocols for universities doing this, so I'm more familiar with this. This is my bread and butter, that's why we picked this.
how accurate, how do you know what frequency associated with specific signals?
He asked, how do we know which frequency associated to the signals?
Yeah, it's in empirical way, or you have some explanation, some theory behind. They say this what
Sorry, I didn't mean to stand in front of you.
associated with this type of signal.
Yes.
Because it must be.
Yeah. So basically, every molecule is going to have its own vibrational frequency, and with the Raman spectroscopy, there are key bonds that show up within the Raman spectrum. For example, for COVID-19, we looked at the sulfur-to-sulfur bond. That's one that's present within the spike protein and shows very distinctly at about 400 to 500 inverse centimeters in the spectrum. And we were able to show that we could detect that single bond there versus for a pure saliva sample that did not have that bond at all present.
Why American government doesn't have this machine?
Good question. Why American government doesn't have the machine? Mostly because at the time, it's only now when the device itself, like the cheapest we can get it is $15,000. About 10 years ago, that was not even. 5 years ago when I did this research, my professor said it cost $70,000 for the same machine. So it was so expensive and required a whole microscope setup that's also about $100,000 each, and that's just not scalable. What we've done is eliminated the entire microscope and said we don't need that. Why don't we just try doing it just with the sample using the laser as is with no other filters needed.
We trust you, but believe me, you probably should receive a Nobel Prize for this thing because everybody suffers, like millions of the people, and you have an answer, right?
I appreciate that. Yes.
So the question is around scalability.
Yes.
So how long does it take, for you to figure out, okay, for this disease, this is what I'm looking for with the Raman?
Okay, so let's use when we did COVID-19 as the example.
Right.
So it took us 2 months to get that test out and to validate it, right? So it took us about 1 month to do the testing, and then the other month was doing the algorithmic work to say, okay, how can we switch out the parameters? Because we used the same algorithm from the bacteria and just said, because all we're doing is changing where the frequency is. So we said, okay, we know it's looking for 500, let's look there instead.
So you're talking about months, as of what you know now.
Yes. So what our plan is with IRB, literally the only thing that's going to take the longest time is how many patients we need to get for each study. That's going to dictate how long it takes.
You see, you're from Kenya, and all of us receive a lot of stuff from Kenya, emails, tons of them. So,
I appreciate that.
Sorry, I think I want to cut you off.
I do have a question. So you're going to be marketing Kenya's market, not United States?
Oh, no, we're marketing here.
Here?
Here.
Okay.
Kenya's just where I'm from, and that's where... So, this device has been used in a pharmaceutical setting to test for drugs, and in an aviation setting to test for explosives or containers. So it's within the FDA, they know about it, but it's not in the physical, it's not in a medical device. So we plan on using a 510K and using the argument to say, you've already recognized this for these other applications, use our device because it lets you do that.
Good news, you have 1 more minute, and it's going to be upstairs, and we can use the elevator.
As a guy, I have bad memories of all this stuff. So when I was at Walgreens, I ran the Theranos program, and shut the Theranos program down. Right. It sounds suspiciously like, a small drop of blood can change the world. So you've just begun the testing of the technology with kind of some sample bacteria in saliva. We haven't kind of dove into that just to validate it for a bunch of different use cases. Just that's still to be done.
That's still to be done. That's what there is before we validate in clinical settings to make sure that we don't have that same situation of, oh, this works and we're not just trust our word to make sure that we have partners who can agree with what we're saying.
So you've done bacteria, but you said that you can tell the difference between cancer and bacteria. Do you have any back up that statement?
So, this is a list of every single, or a selection of studies where they use the same the same type of Raman that we're using to detect all the different cancers. Now, as you can see, well, you can read, what is annoying about this is how they use their nanoparticles, because each one had to make their own, which makes it non-repeatable in a clinical setting. But what we found that the key factor they had was size. The size matched what they're looking for. So So if we can just use the standard approach and just pick the size of the average cancers for that, then we can completely broaden this out and then test, go one by one to really test to see, okay, if they did it, can we make the same experiment work the same way?
So this is the technology, not your technology.
This is the technology. We're trying to test it so we can show our paper to say, this works.
Yeah, the other question I guess I have about that is, the people that are making these products today, what would keep them from creating more of a point of care testing thing, whether it's Baxter or Abbott or any of the other people that are producing these kinds of machines?
It is the liability with the FDA. So because most of them have gone through the pharmaceutical route or tried all the peripherals of the FDA, that has less stringent requirements on their end. But to really go through it, this is one of the things we're learning as we're going through it. Now we're registered partners, and it is, for lack of better words, a nightmare to go through that process. Right? But we think it's well worth it, and we will gladly take the brunt. And for their partner, and for our commercial partner that's helping us, that Metro, that is helping us manufacture this, to them it's like, well, they get to sell a whole lot more spectrometers when they only sell like 20 a month. They can now sell hundreds to thousands without any work on their end, just giving it to us as is. So that's their benefit, not to move any further, because then we just keep doing that.
Have you had any meetings with, pre-sub meetings with FDA yet to understand what they would look for in validation?
So our regulatory partners suggest that we do the study first before we go to that pre-submission meeting, so we have data to show them and say, this is the data we have, this is how our algorithm is going to work, and how we choose to do the update, and then ask them the questions. Because they said if we went in open-handed without any data, clinical data to show them, it wouldn't be as fruitful, because we're paying, because it costs money to get to that point. But like, you might as well do the appropriate studies and take the time, and then use that to basically be a benchmark of them saying, yes, your approach makes sense, or no, we need to do X, Y, Z to just continue.
Okay, one more question. I believe there's one from the crowd.
Thank you so much. I believe in your product.
I'm sorry, we ruled you have to introduce yourself first?
Yeah, my name is Nikita Chizov, Rehab Maker, and Rehab. We are a physical therapy manufacturer. Could you please explain your business model?
Yeah. So, what we choose to do is a subscription business model. We chose this because if we just had a device and we get it and made an outright cost of like, okay, our device costs $20,000. We're saying if we can split that out between the software payment, it allows for easier adoption for clinics. And this is key because clinics, when they're starting out, have a limited budget. And majority of what prohibits them from establishing a clinic is just the cost to set up that lab. Majority of times they'll just forget the lab and just say, we'll just have an office and do all of this. If you have a subscription fee, this fits very well into them. They're saying, okay, at least now off the bat, we can start off with this. And especially with direct primary care clinics, as our subset of the clinics we're looking for, they use a subscription business model, so that fits with us. And two, they don't use insurance, which helps for us for easier adoption.
Other questions? Anyone? Okay. So, if you will take a moment to fill out your form or your online version. Especially impressed with your resiliency and everybody's. I mean, I don't think anybody left, which is amazing. Through the fire drill. So that's the first time this happens. Our 214th event and live event, and it's never happened before. And I'm just impressed that we're all still here. So fantastic job, Isaac. Really good job. Pitching in alleyways, pitching on the street, in front of fire trucks, all along the way, and back up to our journey. So got a little bit extra time, but I think it's okay. Okay, so now I believe we have our final pitch, right? I got a little disoriented as well, right? Jessica, sorry, who has been here? Actually, no, you have not pitched on stage before, but you did really well in the clubhouse. So she actually has her device. Good on her for that. She's going to get 4 minutes to talk about it. So do you want people to pass around the device? Wait, do you want me to bring it around to people? Can I help you?
Why don't I talk to you?
You're going to talk to the device? Okay.
I'll talk to you.
Okay.
And then
Does it talk
afterwards,
back?
during networking,
I see.
I'd like to show you the inside.
Okay, well, let's see. Alrighty then. So, Patrick, she's got 4 ready. Is this working?
Yep.
Okay. Hello world.
Hello, world. Hi, I'm Jessica Bussard. I'm a lifelong technologist, an emergency room nurse, and the founder of Wave Therapeutics. Our suite of smart cushioning devices prevents bed sores, saves lives, and reduces a substantial healthcare expense. So each year, bed sores kill over 60,000 Americans, and they impact the lives of 3 million more. They cost the U.S. economy over almost $11 billion. Regulators say that bed sores are caused by neglect, and facilities need to pay for treatment at an average cost of $44,000 per incident. These wounds are also the second leading reason for malpractice suits. Facilities lose those cases 87% of the time for average damages of $250,000. Our therapeutic wheelchair cushion combines multiple clinically proven therapies with powerful analytics, making Wave the most effective bed sore prevention solution available. After launch, we'll expand our offerings to include full mattress toppers and items for the surgical suite. Next, we'll offer products for the automotive, airline, and consumer markets. Competitive products fall into two categories. First are simple static pads made of foam, gel, or air. They're really not much different than the cushion you're sitting on right now. The current market leader, Roho, makes this type of device. At the higher end are more expensive automated cushions that basically teeter-totter underneath the user. Aquila is the current leader in this space with their $4,000 Air Pulse cushion. It's basically a memory foam pad with some air bladders in it connected to a control box by tubes and wires. It's really bulky and a pain to deal with. Wave's cushion is more effective than anything on the market, and our affordable price allows healthcare facilities to achieve a quick ROI and literally save billions of dollars in liability and treatment costs. Before healthcare, my first career was in global information technology, where I led European business consulting efforts for one of the largest tech companies in the world. For Wave, I've assembled the team of experienced and capable business leaders required to ensure our long-term success. Wave is owned by a woman, and our board and C-suite is made up of women, first-generation immigrants, and members of the LGBT community. We've created 8 generations of prototypes, built out our manufacturing platform, signed a major contract with the Veterans Health Administration, and shipped our first devices to their researchers and reviewers. Our SOM of 38 million comes from the VHA. Our SAM of 500 million comes from all U.S. long-term care facilities. Finally, our domestic TAM of 2.5 billion comes from all the wheelchair users in the United States. We filed our IP in the United States, in Canada, the UK, and the EU, and we've got a placeholder for the rest of the world. We're planning on, as soon as we've established ourselves in the US market, moving abroad. Wave is currently raising a $2 million seed round that will allow us to accelerate our MVP route to market, invest in the R&D of our follow-on products, and pay for critical operating expenses. By initially focusing on the VHA, Wave expects to profitably sell 10,000 units within our first year. Thank you for your interest. There's my contact information, and I'm happy to answer any questions.
Did you have a VHA contract?
Yeah, we do. We signed a CRADA with the VHA back in January, It gives us access to their world-class researchers on wound care and pressure ulcer prevention. It makes us a preferred vendor with the federal government, and they put money on the table to pay for our compliance testing as well as our first round of clinical studies. Now, to that last point, we're a Class 1 exempt product. We don't need clinicals to go to market. All we need is the compliance testing and then to register with the FDA.
I was just going to ask, and so part of what you're getting the money for is to prove out that it works relative to the other existing therapies?
So actually, we're in a really interesting position here because we're based around two existing clinical therapies, alternating pressure and sequential compression. Both of these have been extensively tested and validated. So quite frankly, we're just doing it to be able to brag even more. Also, we've got a strategy ahead of us that once we get those clinical tests in place, we're going to advocate to the FDA that they reclassify us as a Class 2 non-exempt product, which will let us get an even greater reimbursable rate, as well as put a substantial barrier to entry for any follow-on products.
Can you tell us how the product works?
Yeah. So right now, the alternating pressure devices on the market have 2 zones of pressure. Our cushion has 6 zones of pressure, interleaved from front to back, creating a peristaltic pumping action that not only changes up pressure points under the users, but promotes return blood flow from the lower extremities back to the heart and lungs for reoxygenation. Now, in addition, every one of our cushions has a full Linux single board computer built into it with sensors, communication capabilities, and analytics. With our Rev 2 of this product, we'll be able to do predictive analysis on tissue health before problems are even visible to a clinician's eyes, and then proactively change our operation to address that danger condition.
I'm not sure if you mentioned this in audio. Where is this getting manufactured?
Everything is being done domestically. In fact, everything is being done in the state of Indiana. And this is great because it gives me better access to quality control. Plus, I've got so many advocates within state government and state agencies that want to see us bring these valuable federal contracts back to Indiana.
So, and just talk me through the supply chain aspect of how you're managing that and what are the issues?
So from the manufacturing standpoint, we've got 3 vendors that will do various sub-assemblies. Those sub-assemblies will arrive at one of the vendors for final assembly, packaging, and fulfillment. So I don't need to create that. And that vendor also is a well-established medical device company with a QMS facility in place. So it's more things I don't have to build myself. From there, we're going to sell 75% of our B2B sales through distribution. We're going to leave the smaller conglomerates and the mid-sized conglomerates to distribution. And that'll allow Wave to cherry pick the largest of the conglomerates for our own inside sales efforts. So what we can do in 30 sales calls will take the distributor 1,000 sales calls to achieve that same kind of benefit. For our B2C efforts, we'll go through DME providers and our own e-commerce sites.
Time for one last question, if anybody has it.
Anybody?
Give me a hard one.
Up there. Thank you so much. I love this product.
I do too.
Jessica, could you please explain about CPT codes and how it will be reimbursed?
Yeah, so we're going to go to market using the existing HCPCS codes for wheelchair cushion products. We're going to use the same codes that the Roho cushion currently uses right now. So there's not going to be any substantial change or re-education until we've advocated to the FDA to reclassify us. But by that time, we'll be well established in the market, and we'll have that momentum, and it'll be a lot easier to do the re-education. I'll also point out that the VHA is the largest healthcare provider in the United States. And with their buy-in of our product, it's going to make it much easier for us to get buy-in from the other larger facilities.
How much does it cost to build and sell?
Yeah, so our SRP is going to initially be $450, and our COGS, when we get to our production quantities, will be $150. So part of this raise will allow me to buy the automation equipment I need to get my production numbers up and my COGS down.
Can you sell it to truck drivers without compliance?
Yeah. Yep. As well as commuters, frequent flyers, office workers, call center folks. Actually, in a couple of days, I have a call with JetBlue. They're interiors folks. So.
Great. Okay.
Anyone who would like to see more?
So the outside. Okay, so that ends the pitch portion of the night. So if you guys will go through all of your papers or your online. You guys are all okay. Everybody's all done? Okay, so if anybody uses papers, just raise your hand if you use papers, and Tony will come around and get them. Keep your hands up or raise your papers up. Monte will pick us up here. So we're going to do some data entry. Normally we would do a networking break now. There's some back there. Anyway, so normally we would do a networking break, but since we have to be out of here at 9:30, like they're going to lock us out, so we did that once already tonight. You think we get a little extra time? And Brad's got to go at 9. I was thinking maybe that we would just go straight to the future of healthcare in COVID panel. Or do you guys want to break?
Are we going to be able to network it when we're drinking?
I think we have to go to a bar for that, to be honest.
Do it.
Anyway, so, but yeah, so I figured maybe half an hour panel. That's good, right? Yeah. Okay, so all of the panelists, that's all you guys. You guys should all sort of get in a place that I can get you all on one camera. So yeah, all I did is here, and you guys are all done with these things, right? I got here Monday. Okay, does anybody else have more things to turn in? Are you more papers? Still reviewing?
No.
Okay. Okay, so, if you guys want to have a conversation, Sherrod, you guys can go up there. So, I was hoping you guys would have some interesting thoughts on the topics of what are we going to do next in terms of healthcare innovation. I think this event was a bit of an experiment for us. So from my perspective, I'm not sure events are going to come back the same way. What do you guys think? Anyone?
I think you're right.
I mean, the fire drill, was definitely something. So, I don't know, but let's just take each of your areas of expertise, right? So, Sandra, do you think the patient experience has changed much post-COVID?
I actually think that the patient experience has changed somewhat. We're really not in post-COVID time that COVID first happened in the United States, the patient experience with innovation has changed. And as we keep these new technologies, especially the technologies that we talked about this evening, as well as Black & Decker just released some innovative tools for seniors, I think it's going to change more, even more for the patient, and I think that that will be a good thing.
Absolutely. Patrick, you helped Tony with the data.
Yeah.
Sorry, my head was apparently
You're trying to figure out what
completely
the
unclear to
time
everyone.
range is.
I was trying to get you to get Patrick to say, I thought that was pretty clear. No? Okay, so anybody want to comment on that? Sorry, I was.
I think it's absolutely correct, right? I mean, the world has changed significantly, and we've seen a lot very different patient experience post this pandemic. I don't think we're going to go back to it. Well, it won't be totally company lockdown the way we're looking at it. We have some hybrid kind of process, so.
And I think that's great, because I think right now what we have, unlike the past pandemics, the past epidemics that we have, we now have the medical field, we now have the scientific field, we now have politicians all pushing to make sure that the patient knows that they are the drivers of their own health care, and all encouraging them to ask different questions, ask for resources that they need. This was something that this is new, and it's a good news.
Yeah, I can agree with that more. And nobody liked the way it was running before anyway, right? I mean, yeah, maybe the incumbents did. So speaking of which, so how is this going to change things for the incumbents?
Right. Well, I guess what I'd say is I think that the impacts of the pandemic in terms of the explosion of digital health tools and increased use of telemedicine and specialty niche providers, I think has been great and generally good for consumers. But I think that the more impactful change is that those legacy institutional providers have rapidly accelerated their adoption of these technologies as well. So I think it's all cool about Livongo and Teladoc and all that sort of stuff, but they're an infinitesimal part of what happens in healthcare today. What I think is the real dramatic change, I've been a patient at Northwestern forever. I've never had a telemedicine visit. That's what I had. I just messed up my shoulder, lifting weights, did PT. That never would have happened, a year and a half ago, and that's happened across the country. And so I think that change, where these ways of interacting with traditional parts of the healthcare industry for patients has gotten more accessible and easier, is really a profound, I think, and really important change. More important, I think, than a lot of other things.
You don't think that it's just going to bounce back? I mean, the hospitals, the institutions, they're just going to want to go back. I mean,
it only matters. Okay. They're not going to want to do that unless they get paid $1 less for doing something online than they do for doing something in person. So if we're able to maintain payment parity for these visits and figure out how to deal with the fraud issues, which I think are significant, I think that it's here to stay. I'll tell you one quick story about my PT, not to share too much, but as I said, I messed up my shoulder. I had PT. I was at home. My physical therapist was home. So I got my bill, which was great. And I got another bill. Guess what that other bill was?
Facility charge.
It was a facility charge. Well, but and actually, because I'm kind of a jerk sometimes, I asked my physical therapist why I got a facility charge, and she's like, fine. But some stuff's paid for the facility, right? I mean, the facility is not going to go away, but it is ridiculous that there was no use of a facility, but I still got charged the payment. But
as long as the facility still exists, they're going to want to make charges, but it doesn't mean that they've earned it.
Right.
Like when I had an endocrinology visit, it was 7 minutes on a Zoom call. Yeah, it was more convenient for me. Yes, she didn't have to get out of her pajamas either. But they still charge me my $65 copay, and then I'm sure they charge everything. So the cost of doing business goes way down, but the cost of care doesn't, right? So that can't stay like that. And so the payers are driving that, right, by pushing telemedicine and then paying telemedicine rates. And so that,
I think this is the crux of the issue for innovators and in digital health more broadly, is if payment parity goes away, even though maybe it should, because telemedicine and other digital health tools are arguably cheaper to provide, that's going to take us way back and let the incumbents sort of be more dominant again, at least in my view.
Well, Dr. Sarup, I mean, you do surgeries. I mean, that didn't really change, right? I mean, you can't do telesurgery.
You can't do telesurgery, but a lot of perioperative stuff, post-operative visits, et cetera, we can now do remotely. And it's things that we knew we could potentially do, but we weren't, pushing the envelope. So now we've been able to show that, we can do that, and we know when to have patients come in and when not to have patients come in, and how many times we can communicate with them over a telehealth visit and then have them come in. So I think that in that role and in that way, post-operative care is part of a global package, right? So it decreases actually significantly the time, effort, the location fee, et cetera, for hospitals, and it's much more convenient for the patient and the physician or the surgeon. And so I think that there are many different ways that it increases access to health care for our patient population so that they don't have to drive in from, wherever they're driving from, right, from distances. And so, as you were saying about Northwestern, I used to work, our patients came from all over. So it makes things much more convenient for the patients, and it gives us more time to take care of other patients who may need our direct attention.
But, okay, so let's say COVID is a flu going forward. We get a flu shot every year, some people die from it, whatever. It's just part of our existence, which is probably what's going to happen, right? Are you going to go back to the old way?
I don't think that there is the way to go back to the old way.
So it's gone.
I think so. I think that it's part of change that has to occur.
You can head down there. Does everybody think that's true?
I have something to add there. I think you can almost draw a parallel between what's happening, what might happen in healthcare, with what you see with remote work and employers and employees. There was always, I think, a need to do a few things, and you can compare that with what telehealth was 5 years ago, but that's changed now. And to Dr. Sorup's point, I think everyone's exploring the boundaries of what you can do. Can we do more? Can we do less? And then also, what are the ground rules, right? Which goes back to what about reimbursement, or how do we? And I think that's what we need to explore in healthcare, just as you would explore in the corporate scene with remote work.
Well, that sounds like good news for patients, for doctors, for investors. I mean, that means that there's a huge number of opportunities. Whenever there's change, there's opportunity, right? So, from the investor side of the table, do you guys want to weigh in on this one?
On the investment opportunity we see going forward?
Well, you talked about that in the beginning, but I mean, do you think the post-COVID world is going to have a huge impact on portfolio opportunities?
Absolutely. I mean, we've already started to see it across the portfolio. I think if we look at year-over-year comparisons, the adoption and penetration rates of telemedicine are still much higher than they were pre-COVID, but there's going to be some natural tapering for patient visits that are more suitable for an in-person tactile visit. What I will say is a lot of our portfolio companies have structured really innovative contracts with the health plans, which I think is something we haven't talked quite a bit about yet. And so those contracts aren't going to disappear post-COVID, right? And so those health plans now have incentives to make sure that their health plan members are using either lower cost services, or in the case of many of our portfolio companies, value-based payment arrangements, which are going to be more cost advantageous for them in a post-COVID world. So there'll be some natural tapering.
Do you think COVID will have an effect on VBP?
I mean, I hope
I
so, but we're
I
like...
don't see a correlation there. I mean, have you seen that actually happening?
So I would say a lot of the contracts we've seen are more value light. So thinking about how do you structure a capitated case rate model versus value-based care has been slower to adopt than we originally thought it was going to be. So I'm cautiously optimistic.
Yeah, but I just wonder if it's like a, you know, such a chaotic moment led to people adopting new ideas that had been sitting on the side burner, you know, so to speak.
Yeah.
I mean, I thought it was just the opposite, to be honest. Not to start the fight.
Can I?
Yes.
So I actually have a somewhat contrarian position to the question of has COVID changed the way things are going to operate? I actually think it's far too early to tell. And I actually think that what we're saying about the workplace discussion is a perfect example of why it's too early. About 6 months ago, everyone was saying, we will never go back. They were getting out of their real estate positions. And all you're hearing now is you better get back to the office. And so I think that there's a rebound effect that I think we're going to swing back a little bit close to. I think we'll have made changes, and I think we'll have made advancements. I don't think though we're going to experience a sea change here where all of a sudden the old way is gone and there's just a new way.
I'm sorry. Did you introduce yourself?
Oh, sorry. Chris Burns, I'm the Chief Strategy Officer.
Chris Burns. Oh, Chris Burns, the guy we met on Clubhouse. Yeah, that Chris Burns. Good to see you here, Chris. But speaking of Clubhouse, sorry, that was just a segue. So speaking of Clubhouse, this is our 214th event, as we said the first time we've had a fire alarm. Since January 6th, we've done about 585 events on Clubhouse. We've probably engaged 50 times more people than we would have in 6 months, and we've seen about 70% more startups than we would have, some of whom you've met today. And I would say that for us, this room answers your question to some extent. The amount of promotion we did for this event normally would fill the room with twice as many people at least, probably 3 times. But we actually had more people watching us online, some that are actually here in Chicago, than actually came to the event. You got the stats on that? What? Sorry. I'm doing estimates for the people who have flown to the room. Patrick probably has a real number. How you guys doing with the scoring? Do we have to go to
He's working on the algorithm.
Okay, good.
It's machine learning.
How many sets of judging you did?
18.
18. So that means 30 or so of you guys didn't judge. Okay. Actually, I guess what. Anyway, so I had a question before, but if any of you guys have any questions or thoughts on this, let's co-moderate, because I am not really a great moderator. I don't know if you guys noticed that. Because usually I've got too many other things to think about. I don't usually moderate. But honestly, I didn't know any of you well enough to say who's moderating.
I'll ask a question. What is the biggest surprise that you didn't think or thought would happen or has not happened?
You're asking me?
I'm asking you.
Yeah, ask that.
Can you repeat? You said what is the biggest?
What surprise that you thought would happen and then has not happened, or you didn't expect and it didn't happen?
I thought hydrochloroquine was going to work.
I think on that point, I think the biggest surprise to me is that we have vaccines in.
Really? I'm not. There's two things that stop vaccines from happening generally, right? The non-parallel nature of clinical trials and funding. Well, they broke both of those rules, so of course it will pass them. And the mRNA delivery vehicle, the liposome, has been around for a while. I mean, there's just an excuse.
So if I asked you on
I'm
March,
a scientist, I used to make sure.
so if we asked you on March 15th that we would have had an approved vaccine in people's arms in 9 months, you would have said yes.
I had predicted like March the following year. That's why I participated in the clinical trial using a very old technology, using the adenovirus vector. So that was nothing new. Wasn't anything that was going to. I used to make things like that in a lot. But so yeah, I mean, I'm not surprised. I'm surprised by the lack of adoptions. I think you've seen the anti-vaccine movement get an enormous boost in the last 4.5 years. But that's a political discussion.
Going on longer than that.
actually went to an anti-vaxxer event. Me and a bunch of Mr. mentors. One of our investors is big on that. And he asked us to come and debate. And it was, the very beginning of COVID. And it was just amazing the lack of information, the pseudoscience, and the people, of the 40 people there, 35 of them bought into it, full plan and simple. I don't know what they're going to do when they have to get vaccinated to go, to the World Cup or whatever. Yeah, Steve, that's going to happen. He wants to bring everybody to the World Cup this year. Somebody's got to tell him he's getting vaccinated. He might be watching. Anyway, so yes, Jessica, you have a question?
I had a question for the panel about the telehealth discussion that we had earlier. I see a pro and a con to the telehealth question, and I'd like to get your commentary on it. So the con that I see is the quality of the healthcare services provided inferior to the quality of in-person care, because of so much of clinicals is putting your hands on somebody and hearing them and experiencing what's going on. That's the first question. And the second is there a positive, because traditionally marginalized communities can get access to compassionate care that they might not otherwise. And the case that I'm referring to there is the new telehealth company called Plume that provides compassionate care to the transgender community across the nation and gives care to people in geographies that they wouldn't otherwise have. So it's kind of like a pro and a con, and I'd love your thoughts on that.
I can maybe pick us off. To your first question, is the quality subpar? I think the answer that everyone hates, right, is it depends. I think what's really interesting is for some conditions, we've actually seen telemedicine being a more efficacious way of delivering care. So one example, I'll pull on this portfolio company, Diagnose CD. When the patient is actually in the context of their home and they're able to have exposure therapy and experience some of their fears or anxieties in the context of their day-to-day life, the outcomes are actually superior. We've seen a lot of that in some of our pediatric telehealth solutions too, where they're leveraging family-based models where the parents and the siblings are all actually able to participate on video with the provider because it's just more seamless, right? They're in their home, they're living their day-to-day life, they're not confined to this new clinical environment. Certainly can't speak to the more, again, tactile engagements that you were referencing, but I think that's been a really interesting observation for us where in some cases telemedicine can actually be superior.
And I'd like to offer my opinion from a patient standpoint, a patient that actually represents one of the marginalized communities, not all of them, but one of the marginalized communities. I believe that the telehealth does have some advantages for that marginalized community, and that the patient, right now when a patient goes into the office and talks to a doctor, they don't ask all the questions that they should ask, so they tend to be quiet, they go home, and then it's like, if you ask them what the doctor said, they have no clue because they're quiet and they don't know what the doctor is actually talking about. Well, a patient that's at home is more comfortable being at home, so they can ask those questions that need to be asked. They can ask them at home with relatively, at ease because they're in the comforts of their home. The downside of that, though, is that there are a lot of people that are in the marginalized communities, and I'll take COVID for an example. A lot of marginalized community members they suffered COVID, but they suffered more from an underlying condition that wasn't caught. Telehealth is not going to help catch that. You have to actually see the patient in order to actually be able to know, okay, this is what's going on, because once again, you have to see the person and talk to the person to know. So there are some pros and cons to telehealth.
patient care, like a post-appendectomy patient, right? Seeing someone takes maybe 2 to 3 minutes max. Patients are usually like, that's it? Yep, that's it. Just need you to check this and this and give you your pathology and bye. You know what I mean? So it's a very quick visit versus other patients who, are doing their own wound care, et cetera, and it's a continued process. And what we learned is that if I'm able to see what you're seeing and examine your wound from picture or from, like live streaming it, right? And I can give you comfort that everything is going okay, and we don't have to see you and put you at risk every week or have you drive from your home from from a far distance, then it saves patients money, it saves them costs, et cetera. Now, if there's a problem, right, and it's not expressed appropriately, just like, I'm sorry, Rachel was saying, it really does depend, right? Because if there's something that's lost in translation, then sometimes, you can have a little bit of an issue. I have one patient who's actually a physician whose wound was red, and he kept telling me that it wasn't red, and he would send me these like weirdly lit pictures, and he was like, no, it's fine, it's fine, it's fine. I was like, it looks a little, and so finally I sent him to the emergency department, and he actually did have an issue. But, so there's everything has pros and cons to it, and what I wanted to make sure and say to what Chris had said is, I don't think that the whole world is going to change, but it's never going to go back to exactly how it was before, where everybody's going to be going back to work, where every single patient is going to be seen in a clinic. There'll probably be some mixture of telehealth used, and there'll be some remote work that's done, because we just can't go back to how it was, because now we know the possibilities that we can actually use. So, and I think I could probably see in mental health where, that the usage of telehealth could be very nice as well. Thank you so much.
Appreciate the answers. We have we only have a few more minutes before a couple of the panelists have to leave, and then we just go to networking and people can ask questions directly. But we do have to be out here by 9:30, so it's not going to go on that long, at least not here. So, I don't think we've heard very much from Heather Walsh tonight. So, Heather, and actually this goes to all the people who are really involved in healthcare innovation. How has healthcare innovation changed from your perspective in terms of whether you're a very successful, well-known entrepreneur in healthcare innovation like Khan or Rohini, who's starting their company and growing, or from the number of applications you get and what you're seeing in your applications?
Yeah, I'll take the last one first because that one is a little bit easier. So we just opened applications. We haven't had that many, it's been like a week, but the first ones we're getting are all sort of COVID related in terms of hand washing and sanitizing and mask technology and all of those kinds of things. That's not exactly what we're looking for the accelerator, but that's what we're getting so far. What we're looking for on the accelerator side, I think, does align with some of the changes that we've seen peri-COVID. I like that term because we keep not being able to do stuff I want to do, so we're tackling that post-COVID. But what we're looking for with our partners like Baxter and Edward Elmhurst is as people are seeing sort of some care happening in the home or telehealth or all of these things, because we're on the hardware side of things, we're not looking at platforms for telehealth or algorithms, but we're looking at what are the devices that actually support all of that. So the telehealth, the change to increase we've seen some of these things today, getting data to support some of that care that you're getting in the home or getting outside of the clinic and even in the hospitals. And then secondarily, we don't want to just look at sort of how physicians are getting data, but how they're providing care as well. And so, during COVID, when hospitals
it increased over that period of time because it was much safer for a lot of these very sick patients to stay in their homes. And you see a lot of, increased, better outcomes coming from patients who are continually doing dialysis therapy every night in their homes, and it's more convenient for them. And so some of these things that we saw happening over many, many years, they sort of speeded up a little bit. And so I think those were things that were started maybe 4 or 5 years ago, but that opens up the doors to what other things can you provide care with in the home, and how much expertise does that really entail? So I think dialysis is a very complicated modality, but now that people are doing that in the home, what other kind of care can they do in the home, and what expertise do you actually need to separate that?
Yeah, those are all really interesting points. Colin, do you want to talk about how your Hyperfine, has been rolling out through this pandemic? Has it affected you guys? I mean, I would say things are probably easier for you than most people, but.
Yeah, I think it also depends on how you think about
Thanks for
anything.
coming.
Yeah.
Round of applause.
Yeah, I think it also things about how do you prepare all about. I mean, the reason we were prepared and we were able to accelerate the way we did was just the team that was initially put together and how they were thinking about progress and future of it. I mean, we were doing iterative development on hardware, right, which is typically not done that way. So, like, we were doing our pre-planning for COVID in second week of March, and really understanding our supply chain, understanding our remote working capabilities in a hardware manufacturing company, right? So where we need actually engineers touching magnets and things that they can't take home, right? Because it's not possible to do that stuff. So then that meant, can we get our facility clear away so we can actually do point of care testing every morning and arrive, and can we do it in less than 15 minutes? So a lot of the planning in March happened, get the PPEs in, get us ready for the kind of testing, and just be not to execute on it, but to understand and build a plan around it, so that if lockdown happens, we were ready to move forward with that. So we accelerated our R&D efforts by 6 months ahead of schedule, right? So, and because in end of March, after getting calls from New York hospitals, like, hey, we have 110 patient ICU, every single ventilator is being used. I don't know if the patient has stroke or what is going on. Can't take him down to MRI because I don't have a portable ventilator. The staff is not available to pump them. I need a scanner. Can you get a scanner tomorrow? And like, it's not approved by FDA yet because we were still getting ready for that.
That's a great story. So you used COVID to accelerate the adoption of your Hyperfine.
Yeah, I mean, we launched 6 months ahead. So we were supposed to launch at the Radioxide North America Conference here in Chicago in December of 2020.
Yeah.
And the first scanner was in the hospital in April. Right, so that was way ahead of schedule, right? And our FDA clearance happened in August. So we called FDA, they said, safe device, MR, no radiation, nothing. So didn't even say, forget, early authorization and just go. So we were delivering scanners in tri-state area hospitals to do this. So we even delivered COVID. The farthest we went was East Chicago, is the farthest we were able to drive.
Maybe we've got a new aphorism. They say luck favors the prepared mind, but bad luck favors the prepared entrepreneur.
I think that's the thing. The companies that survive crises like these, the companies that survived 2008 financial crisis, going to survive this, those will excel and just grow in a rapid space and be able to do a lot of interesting things. So yeah, I mean, and that helped us prepare to go global. And I mean, the whole mission of Hyperfine was to build a point of care MRI scanner, which is mind-boggling, right? It's like you're taking this magnet that requires $1 million plus to put in a room, now you're taking it out there. And one thing Jonathan Rosberg, who founded the company, the same guy who founded Butterfly, that ultrasound, one of the missions was that we need to make sure we understand the low resource setting use case and environment, not just designed for the ICUs here in the US, but design how it's going to be used in Sub-Saharan African Community Center, in India, places like that. So as part of that, earlier on, focus was that how do we do that? How do we understand that aspect of it? So we've got to actually Gates Foundation approached us with a grant to put 20 scanners in limited resource settings. And this ability to do this in pandemic and where we can't go to the hospitals to train people. We have to deliver it and get to leave it as a loading dock. And they have to open it, never use it, learn how to turn it on, drive into the ICU, start scanning patients, all virtually. That helped us prepare our first delivery to Malawi, right? In Malawi, Africa, the scanner arrived, the customers opened up and were scanning the first 4 hours of delivery, which is like unheard of, right? So all this pandemic and accelerated a lot of these processes, a lot of the thought process, and really helped us prepare and think about how to do these things in a much more effective way. So, I mean, it required a lot of behavior change, and not only from our preconceived ideas on how these are going to be, but actually from customers themselves, like, what do you mean there's nobody going to come and train us and live for a whole 2 weeks telling us how to do this kind of stuff? I mean, I think eventually we need to do that because customer success doesn't happen by just dropping things off. But anyway, lots of learning.
You took an impediment to the world and
Just,
turned it.
other people have things they get good at. But yes, he definitely took an impediment. Bradley, before you go, since you're the first one has to go, give me your prediction. I'm sorry, I'm going to get to you. I just know Brad has to go. We can get back to this topic. We can continue about, or we can. But I know Brad's going to go. So I wanted people to sort of give me a tweet, give me a short version, and just go down the line of what you think the future holds in this, what do we call it, peri-COVID resistance, for your particular area of interest or expertise, right? So something like, this will be like this because of this, and that will be this way. I don't know.
Well, I guess what I'd say is that what's happened in the last 16, 17 months has, I think, accelerated a lot of change that was slowly moving along. And I think things like remote patient monitoring, providing support for independent living, consolidation of physician practices, kind of industrialization of medicine to some extent, has just accelerated, I think, much more rapidly. It was already going to happen, but it probably took a decade off of that trend if the pandemic had not been rolled out.
So you don't think this is a rubber band that's going to snap back? Do you think they broke through and it's just going to keep on going?
Well, I don't think it's going to snap back a little bit. I mean, I was in New York during September 11th. I mean, we all thought our entire world was never going to be the same again, and obviously it's a very different, specific kind of thing, but it's similar. We are all who we are, and we all kind of will drift back a little bit to our old ways, and profits, incentives in the industry are still the same way, so people are still going to try to be making their money off the system in ways that they traditionally have. But some of it's not going back. I mean, I think 70% of physicians now are employed. That's happened. That's
a way that goes up and down.
Well, maybe they'll spin them off again, but most of them are owned by hospitals, some on private equity roll-ups like Village MD here in Chicagoland area. So I don't know that that's going to go back. So I don't know. I hope it does go back.
Interesting. Sandra Washington, would you like to give your forecast of what's going to happen?
Yes.
Brad, if you have to go, I'll just slap you out. Go ahead.
I do. Once again, what I see for the patient in the foreseeable future is great things to come along with the introduction of innovations. It's good that the patient is no longer being kept to the side, but actually brought into the middle of the conversation, and the focus of the medical industry now is on the patient, which is where it should be. And we're being allowed to push forward by actually saying what it is and what we want. We're being allowed to advocate for ourselves, and more doctors are listening and just, having us come along as equal partners. So that's a good thing. Because as innovations come, we'll be at the forefront, not in the middle, being introduced to something that's already on the market. So I only see the good things coming to patients as we continue to move forward in this COVID.
It's a good new term, I never heard of it, it's a good term. Well, I'm glad you didn't walk out on the patient, Brad, I know you're gonna
I
go.
never would walk out.
Exactly, so, just a round of applause for Brad. Okay, so, we can finish this up real quick, and then, we have to leave by 9:30, then we're gonna do some results, so, let's just keep on going down the line, Rohini.
We focused a lot on telehealth and digital health, but I think the pandemic also challenged healthcare organizations, providers, anyone who provides care, right, in ways that we did not expect to see. And it required healthcare organizations to be so much more nimble and agile and change in a very short duration. It stretched everyone so thin. I feel like that's a change in state of mind. And now, yes, it was caused by the pandemic, but I think it's shown healthcare organizations that they can actually be a little more nimble than they imagined that they were, whether it's operationally or even in terms of providing care. So there's much more, I think, even beyond telehealth and the wide adoption of telehealth. But yes, it's a change in state of mind to say, hey, we did it during pandemic, right?
They've gone from
Right.
to active.
Right.
Con?
I think change is inevitable